I'm really glad. We thought we'd do this slightly differently where we had some more voices. Is that all right? But also, I'm going to throw it out to you guys. So those of you who work in primary care, feel free to dib in. And if you don't work in primary care, just dib in anyway. Is that right? Pretend you're a doctor. You've all watched Holby City, so you can all do it. It's fine. So we've got Emily. So do you want to say, first of all, do you want to introduce yourself? Say a little about you. And I think we're going to go with what's your favourite chocolate bar. So your name, your job, and what's your favourite chocolate bar, is that right?
Okay, so hi everyone, I'm Emily, I'm a GP trainee, so I'm ST2 now, as part of the Greater Manchester Deprivation Programme, which is linked to Shared Health, which is why I'm here. And favourite chocolate bar, easy peasy, Kinder Bueno.
Really? Oh, yeah. Gross. Right, pass the mic to Alan. Alan, what's your name and where you come from?
I come from Aberdeen in Scotland, but I've been down in Manchester since I think about 88-ish, and at my practice in Glossop since 1995.
Wow. Emily, that's something to aspire to, isn't it? And what's your favourite chocolate bar?
Well, I've got to be careful with favourite chocolate bars, but I might break my promises for a chocolate Easter egg.
An Easter egg? Oh, yeah. I love an Easter egg. I don't know how the chocolate tastes different just because it's round. It seems to, doesn't it? Right, go on, Raja.
What do you want me to say?
Wait, come on, get with the programme. Your name, where you come from, what's your favourite chocolate bar? It's a good job we've got 10 people on this panel, isn't it? It'll take a while.
I'm Murugesh Raj. I'm a GP. I've been a GP since 2011. So it's 11 years now.
There you go.
And yeah, working with health inequalities for that long time. My favourite chocolate would be a Toblerone.
A Toblerone? Well, the good thing about Toblerones is you can get massive ones, can't you? Yeah, the ones in the airport that you think, why did I buy this? I didn't need it really. Okay, so we asked you guys to just share a little bit. So I think about what do you think good primary care looks like in areas of deprivation. So Alan, do you want to kick us off? You can go first with all your experience.
It was me thinking I was safe in the middle.
Oh, there you go.
So I thought I would just say a few things that we were lucky to introduce in our practice, more or less when I took over in 1995 and that have worked for us. I do practice in an area that would be classified as one of the high areas of socio-economic deprivation, and have done since, and very much have loved being in a small practice with a population I know, and I think that probably colours what I'm going to say. But first of my 5 points was to give a shout to our practice receptionists, who I think have really been the front line of general practice primary care, especially during the pandemic. But a team of people who actually want to help people and know who they're talking to, fantastic, irreplaceable.
Have you ever sat on reception, Alan?
Well, I think my receptionists try and keep me away from reception, because it's not something I'm very good at.
No, I offered to help, and now if I literally sit down in the chair, it's amazing how many people appear. Oh no, don't you, Laura, off you go, out of the way. So, yeah, definitely moved on. It's difficult, it's a really difficult task, isn't it? But that thing of having people that want to help, that care and know our population, our patients is so important, isn't it? Great one.
So my second point would be that we've had a completely unlimited, urgent offer to our population since I started. So pre-pandemic, that would mean there's none of the 8 to 9 phone call rush. There's none of the we've seen as many people as we can. It meant the door was open from 8:30 to 12:30. And if you have an urgent problem, you came in. Latterly, since the pandemic, that's turned to an unlimited telephone offer. And I think the open door proved it is doable. There are a lot of people that say demand is infinite. But I can tell you, if you leave the door open, eventually people stop coming through it because the day's need has been met. We've found it really complicated, sort of post-peak of pandemic, because we're getting a lot of urgent problems from the supermarket or urgent problems while I'm out shopping in a mall. But before that, when people presented with genuinely urgent problems, demand is finite and you can meet it.
That is really challenging. Yeah. We have not quite managed to do that yet, but I will keep thinking about that one, Alan. That makes me feel a little scared, if I'm honest.
Yeah, I wouldn't like to be starting it now.
Oh, good, great, thank you.
But knowing that it has worked, we are buckling a bit, as I say, with some of the, it's easier to be urgent on the phone. I think we haven't worked out how to come to terms with that yet. And then when you actually say, it's not urgent, it should be a routine appointment, I think then it's all very difficult. But that would bring me to my third point. And I think especially in the context of the day, people with lots of problems need longer time. We've always run, well, not always actually, we introduced a 15-minute routine clinic some years after I started. We started with one 15-minute clinic. When we saw it worked, we changed all the doctors' clinics to 15 minutes. And at the moment, we're even experimenting with one that's running longer than that for people with multifactorial problems. But also, during those longer appointments, we don't limit the number of problems that you can come with. If you do choose to come with 6, well, then you've chosen 6 problems. They all need addressed. Why not just do it at the time? Why put it off and address them later? So that balance of an urgent offer, which is often quicker appointments, and a longer, more in-depth offer, I think covers a lot of bases, and it lets you explore things in more detail. It gives people more time. And as that fantastic quote you had as well, it is a moment, isn't it? It's an opportunity. And a bit longer, a bit less pressure, a bit easier to take advantage of the opportunity.
It's interesting, isn't it? I really like the fact that, I mean, Alan, you've been doing it a long time, and you get the sense that you're still learning and still changing stuff. It doesn't sit still, does it?
Well, no. I mean, the pandemic, I think showed some of the flexibility of general practice at its finest, that we could adopt things that we might have thought about for a long time, but were forced to change and just changed within days, within hours. We're so lucky there was some good modern technology at the same time. But if we hadn't been the kind of organizations that could pick it up and run with it, wow, where would we have been if we could only work to the old model? That would have been a disaster.
It's amazing, isn't it? Right. Is that 3? Have you got 5?
That's 3.
7?
I've got 5. I can speed up. So the fourth one would be, and again very pertinent, the offer of continuity of care. And I should confess, I'm Honorary Secretary of the Family Doctors Association, and that is the raison d'etre, really, of that organisation. But there's so much proof for it, and yet, sadly, it often isn't reflected in our public policy. We know it does so much, as well as increases satisfaction for patient, clinicians, frontline staff. And again, to mention reception, of course, continuity isn't just about doctors or about clinicians, nurses. It begins with reception. And we tried to do a few technical things to maximize that. So even in our urgent clinic, we try and give people choice of doctor. But then when we see people in our routine clinics, we do the direct booking ourselves. We arrange the follow-up ourselves. And we keep things with the same clinician of the patient's choice as much as we can. And the last thing is there's no point in continuity, though, unless you actually have a good offer for people. And I think the offer is patient-centered care. And I have seen that term very much used as a label to make something right, to sell a campaign. But actually, if you only see the medicalization and the medical problem, and you don't see the person in front of you, as a family doctor, I think you're missing the point, really. The person that comes with the context of their psychosocial problems, their life, their experience, you've got to see the person. If you only see the problem, you're doing a very small part of the job. That would be my 5 points.
That's it, yeah. And I think my experience is that even the most broken people are beautiful, aren't they? You know, so if it's just a problem list, it's overwhelming, isn't it? Like if it's always like problem, then it becomes very much about you solving problems. But if it's about a person, then some of the problems might not be solvable, but there's still kind of beauty in there, isn't there? So, right, Alan, remind me to never come and work for you because it sounds like the bar is quite high. But that's brilliant. So continuity, access, a relationship really with the receptionist, with the whole team, and giving people time to be human, really, isn't it? That's great. Raja, what top tips have you got for us?
I think more than top tips, I mean, sometimes we talk about the definition, if I come just from a GP angle, often called as the gatekeepers, or I think there was some debate in the council recently and they were talking about us being the navigators of care. And I think, this might be just an anecdote or observation that we're kind of becoming, because of the pressures and the demands, that we're becoming like a traffic policeman. Oh, this issue, you go there. This issue, you go there. This issue, you go there. But then this is not my idea. I always learn from someone that we as GPs, including all the staff, we own the patient or we own the house. I think we're all probably, some of us are fortunate to own a house. And the example is if the plumbing goes wrong, I call a plumber to fix the plumbing, but the house is still mine. And if there's something problem with the boiler, I call the gas man and he fixes it. The house is still mine. So I kind of think the same with our patients, because even though they might have a urology problem, which I may need some help from the urologist, but I still own the patient. He's mine or they're mine. I need to think about what's best for them, and we need to work out a plan on what works best for them. So I think it's all about the relationship building, knowing about them, because the Addison's disease or the nephrotic syndrome or the heart failure doesn't mean a thing if you don't really understand that they actually have to go back home and care for their children with learning disability and still live in that difficulty and then forget not being able to afford the utilities that we talked about. So how can you be a navigator of care, or you need to go to nephrologist, or you need to go to the cardiologist? That's not going to work. You just have to understand them, build a relationship with them, care for them. Few words, moments of change. And then, of course, they really want to see you. And then how do you create that access and that barrier of access? I've kind of worked with models where we did the urgent calls, but then we realize it's the same patients keep coming again and again, because it's just that you've never addressed the whole of it. You've never addressed the whole person. And I think that's what's more important, in my view, about general practice. So we become not just gatekeepers or navigators of care. We become, the friend, the doctors, the one who actually cares about them and one who can treat them. And sometimes they come in, you've never really sorted anything out for them, but they still go out much more happier and with a bit of hope. And that hope kind of carries them through possibly the next couple of days, and then they're back again within the life that they live in. So I think as GPs, we're challenged to think, yes, we are pressured all the time, but I think we have a very important role. And that role kind of transcends, once you said the example, then of course, the practice nurse is great inspiration for us. Receptionist, a good receptionist can make so much things better for our patients because they know everything about them. And I often talk to them about them once, if I'm going to see them for the first time, and they often give us a lot more detail that is so much important for us. And working in a place where I work, where we have focus care workers, it's just helpful because I can't sort any of the social problem, but it all needs sorting out. And if you can't do that, then of course, how are you going to treat all the medical problems that I just highlighted? Because it just becomes increasingly, it's the challenges are increasing, and I think that just gets more busy. And lots of people are coming in with problems now that they are struggling with the system. whether it's barriers to access to us or to secondary care or to wherever, or access to even simple things like utilities that we talked about. So how do we break those barriers? And these people are the same ones who've already faced so many barriers in their lives already. Even to come and sit in that room to see me, I tell you, it must have been very hard, especially the young ones who come, or even the example of the Samaritan women that Laura gave, I see them all the time. Even a big challenge to even say the first word on how, this doctor is going to be. And you can make it or break it in that exact moment of change. So each consultation is important.
Yeah.
You never know what sits behind that person. You just have to pause, give them the care. And for that, I think more important is to care for yourself. And I think I've just realized that you've got to look after yourself, because if we are kind of stressed and running around, then where can we get the empathy from? Where can we get that understanding? Where can we get that care from? We have to look after ourselves to be able to do that. And we need to kind of work in places where there's, there's talk about well-being, where there's talk about how we can look after ourselves to be able to look after others. And I think that's the challenge we all have, during this time. And we can't blame any one single thing. It's easier to blame.
It's always Boris.
I can always blame anything that we want, but sometimes I just blame the chair that I sit on. It's never comfortable, and then you still carry on. But it's a challenge, Laura. I don't have all the solutions.
I love the
but
idea
we
of
can
you
try.
muttering to yourself about your chair, Roger, and then cracking on anyway. So there's lots in that, isn't there? So we're going to unpack some of this later in the day. So looking after ourselves is really important. Seeing the whole person, trying to remember that it is quite brave to go and see a doctor or a social worker, or isn't it? I don't know if any of you. I was a patient a couple of weeks ago, and I'd booked off the last hour of the day, and by the time I got there, I was like a gibbering wreck. And then I burst into tears before I said a word. You just think, oh, for goodness sake. But, if that's me, by the time I came out, I was sat in the car and I was like, oh my goodness, I definitely need a dairy milk. But yeah, that kind of, it's brave, isn't it, to go and say things that are vulnerable. And I think when you sit the other side of the chair, I know when I see patients that I can get irritated when they do the, 3-minute build up to the actual point. You're like, come on, what's the point? But when it's you forget, don't you? Suddenly remember, don't you, how vulnerable that is actually. Right, Emily, you're our newbie. So we're going to leave you a quick, anything you want to share about, like, from your short experience of general practice, things that make it go well.
Yeah, correct. Very short experience so far, sat alongside lots of wealth experience. But I guess I'm here to sing, dance and talk all day about the Manchester Deprivation Training Scheme because I love it. I think it's brilliant. And what makes it different from other training schemes, GP training schemes, is that our placements and our teaching is very much geared to developing the tools and the resilience, I guess, bit of a buzzword, but the resilience to sort of work with these populations and try and tackle some of the problems that we've touched on that I'm sure we'll talk about more later. But basically tackling health inequalities and having the ability to sort of stay working in those areas. And I think that's been proven already. A couple of our friends that have CCT'd recently, they've stayed at the practice that they've trained in, in areas of deprivation. And, that is down to the training programme. So, yeah, I'm happy to talk about that all day if anybody wants to come and chat later.
Yeah, so I said when we started the deprivation training scheme, we're like, it's teachable. Working in these areas is teachable. It's infectious. We talk about it like it's best to surf when the waves are highest. Nobody wants to surf in the, when the waves are piddly. So, but to learn to surf, you have to have some skill. So it's teachable, it's infectious, and I want to be a doctor that is still seeing patients in 20 years' time, and loving it still. And that's what we want, isn't it? So a few things from me. For those of you in the room, I have become a convert to the power of Arden's searches. So I'm not the most technical person, but the stuff about, access and compassion and relationship and everything is absolutely brilliant, and I will always hold that up. But just to balance that, I've also become a convert to the power of using data to find those who haven't been found. And we've run various searches at our practice in the last couple of months and found people who actually are right on the fringes. And we, if we'd waited for them to tip up to us, that might have been another couple of years, but we found them and called them in. And, we're still, some of them we're doing that journey of we've called you, or you're not coming, we've called you, you're still not coming. But they're interesting that they're there. So the power of our data to find invisible people, I think, is really important. And the other one I love is that we don't exception people in QOF until the final week. And you have to have this, the bar to exception report is quite high. But I love it because in practice, in some of the practices that are a bit more kind of on it, that last week we send the nurses out door knocking. And they go and door knock on the people we haven't seen all year. And they're often like the people with like 10 chronic diseases who you think got a leg hanging off somewhere in the living room. And they go and door knock. And that week is like amazing week of finding people. So you don't get the QOF points because it's too late to do anything. But it's like the time of the year where we find them, we know them. They're suddenly glaringly there on the computer screen in every search. And then we set them up for the April. So it's just cyclical things that kind of help keep you going, really. And there's nothing like knocking on a door and finding someone in an absolute desperate situation and knowing you found them. Like we've every year in March we find people who've had electricity cut off, run out of food, living with like infestations, abandoned by family, living with surrounded by cans of cider or whatever. And to know you've knocked on the door and you haven't solved the problems and it's still going to be there next week, but at least someone knows they're there and they care. For me, I love that week. So I hate the coding, but I love that week. So has anyone else got anything that they'd like to share? We've got a couple of minutes, so anyone sitting here, let's pull the wisdom. Anyone who's got any ideas of making primary care work really well? Oh, good. I'm excited.
Laura, I can go.
Yeah.
Like the dentist table. What are Ardens?
Oh, yeah. Oh, sorry. Sorry for the dentists. Oh, I'm really sorry. I've been talking in gibberish all morning. So primary care has a computer system called EMIS, which is brilliant, much better than the hospital system. And it's got really good coding in it. Some geeky GP invented it in like the 90s, and they're really good. And then Ardens is this new software that interrogates that. So you can find anything. It will find you people with like 6 left toenails and a squiffy nose. It can. So it's the power of it is amazing, and it does these searches, and it also interrogates all the results data. So if you find people with like, I don't know, platelets of a certain number, it will bring them up. So it's new. It's landed in our practice in a couple of years. It looks really frightening. It looks like when you go onto the Ardens screen, it's like watching teletext from the 80s. It's just like lines of numbers and data, and you're like, oh my goodness me. But underneath it, it's amazing. Teeth is fascinating. We've got you guys here because teeth is... we have primary care coding for like mouth ulcers and suspected cancers and things like that. We've got some for terrible, caries, and we code letters. So we do code children who've had teeth extracted. But yeah, teeth is something that we've got you guys because we know that if you look at, I think a marker of deprivation and inequality is teeth actually. And it follows, doesn't it? When we see our childhood carie rate go up, a couple of years later we see our diabetes rate go up and everything else go up. So it's like, for me, it's like an early warning system, teeth. And our public health data on teeth is appalling at the moment. So we're really glad you guys are here. Right, any other questions that I've been gibbering on in gibberish about? No? Oh, go on, Liz. No, then.
Liz,
Can I ask Alan a political question? No, Liz.
Just about, it's really about the funding and the differential funding. There has been something in the GP press recently that there may be more consideration for, or acceptance, realisation that deprivation needs more funding. Is that a dream, or is it likely to become a reality?
Do you want to answer that, Alan, or shall I say it's time for coffee? A little bit. So this is we're not going to go down a funding thing, and the other rule of the day is if the fire alarm goes off, obviously you go out the building, but the other rule of the day is we're not going to turn into the whingy people. All right, Liz? So funding is always a pain, Right, you've got 30 seconds on Liz's funding question.
Did you say 5 seconds? Excellent. 5, 4. So there have been various variations over the years of trying to move funding in general practice, that's the only bit I know about, into areas where there are higher levels of deprivation. And one of the things we know with the retirement crisis of general practice at the moment is it is primarily GP partners that are retiring, and it is primarily in the areas that are worse off. So we already start from a very bad place, and it's accelerating the most in those places, exactly the opposite of what we want. I think the difficulty with moving funding, unless you can level up, there are always losers. And actually some of the equations that have been used and complicated before, where you just think about one aspect, you can forget other aspects, and that doesn't work. So we learn that if you only look at just general practice again, funding in areas of poor health, what about areas where most of your population is a lot older? And they might really be well, but actually they're not really well, because if you've got an old population, you've got lots of problems there. I think the world we live in is so complicated with so many different angles that addressing it properly is a big consideration. And that's why there haven't been, I think, great clear strides, because it's difficult. I do remember a few years ago when there was a waiting to work in areas that were harder to work in, which does seem to link with some of the activity that you see as a GP, that it seemed to be beginning to move general practice to the right people. This Manchester deprivation training scheme, fantastic idea. It's an example of a different way of doing it. And people staying on. We in our practice have had so many people staying on with us after they've done the registrar year. Maybe not forever, and then they go on somewhere else. But initially, I think that's a big thing. Training people, getting people into the areas where they're needed most, and then them staying on. There's a possible future in that.